Hello, dear students and friends. Welcome to my lecture series on Cesarean section 360-degree. Cesarean section, as you know, is the commonest surgical procedure being performed. In this series, we will explore fascinating journey from anatomy and applied topography to safe, effective cesarean delivery through a step-by-step understanding of surgical landmarks, operative techniques, and practical considerations. This series aims to strengthen concepts, improve precision, and enhance surgical confidence. Together, let us bridge the gap between anatomical knowledge and real operative practice. At the outset, as an introduction, I would like to show you an excellent video on applied anatomical topography for cesarean section.
In advanced obstetric surgery, textbooks serve as a baseline, but the operative field is dynamic. Natural physiological variability, compounded by the shifts of pregnancy, requires surgeons to maintain precise intraoperative navigation. This navigation relies on anatomical mapping, the systematic process of identifying the exact depth, location, and spatial relationships of organs, vessels, and tissues before an incision is made. The anterior abdominal wall functions as a highly stratified, layered biomechanical system. Identifying these specific layers and their relationships serves as the foundation for optimizing surgical outcomes and minimizing iatrogenic complications during high acuity deliveries. The structural logic begins at the skin. The dermis follows the natural alignment of connective tissue known as Langer lines. Making an incision parallel to these lines, as seen in Fan and Steve or Joel Cohen techniques, reduces the tensile forces acting on the wound edges. This mechanical alignment facilitates better tissue approximation and healing. Deep to the dermis, the infraumbilical subcutaneous tissue is a strictly bilaminar structure reinforced by elastic and collagen fibers. In this cross-section of the abdominal layers, the superficial adipose layer is clearly visible. Historically termed Camper's fascia, it is defined by a variable areolar architecture and adipose tissue content. Directly beneath this is the deep component, the membranous layer, or Scarpa's fascia. This membranous layer maintains anatomical continuity across the inguinal arch, extending caudally into the perineum as the superficial perineal fascia. Respecting these specific tension vectors and fascial planes during entry and closure helps prevent widened scars and reduces the risk of incisional dehiscence. Past the superficial fascia, the core structure of the abdominal wall is formed by three broad, flat lateral muscle groups. These include the external oblique, the internal oblique, and the deepest layer, the transversus abdominis. The medial aponeurotic extensions of these muscles converge to construct the rectus sheath, which envelops the vertical rectus abdominis and pyramidalis muscles. At the midline, these aponeurotic layers interlace to form the linea alba, the primary fibrous anchor of the anterior wall. The pyramidalis muscle, originating from the pubis, functions to increase tension within the linea alba. Because of its midline position, it serves as a critical landmark for median surgical approaches. Approximately 1/3 of the distance from the umbilicus to the pubic tubercle, we find a structural transition point, the arcuate line. Above this line, the aponeurastes form a complete anterior and posterior sheath around the superior 3/4 of the rectus muscle. Below the arcuate line, the posterior sheath terminates. The inferior rectus muscle rests directly against the transversalis fascia, with all layers passing anteriorly. Recognizing this transition is essential for identifying fascial layers during deep suturing to ensure the structural integrity of the lower abdominal wall is maintained. This musculo-aponeurotic core is supported by a specific arterial network that surgeons must map to manage hemostasis. The lower abdominal region receives lateral perfusion from branches of the femoral artery, specifically the circumflex iliac system. Medially, the primary vascular supply comes from the inferior epigastric artery. The deep circumflex iliac artery provides the complementary supply for the lateral compartment. Superior to the umbilicus, the inferior and superior epigastric arteries converge. This creates an interconnected web of vessels that also links with the inferior intercostal arteries. Mapping this epigastric grid is necessary before extending incisions. Inadvertent transection of these primary axial vessels can result in significant rectus sheath hematomas that are difficult to control. The neural architecture of the abdominal wall is supplied by the thoracoabdominal nerves from T7 to T11, along with the subcostal nerve at T12. These nerves follow an infero-anterior trajectory, moving from the intercostal spaces into the abdominal musculature. They traverse a specific neurovascular plane situated between the internal oblique and the transversus abdominis musculature. This plane is the target for regional anesthetic techniques in cesarean delivery, which can significantly reduce postoperative opioid requirements. As these nerves continue, their anterior cutaneous branches perforate the rectus sheath near the midline to reach the skin. If these neural structures are incorporated into the fascial closure of an incision, it can result in nerve entrapment syndrome, a condition characterized by localized pain, numbness, or tingling. Navigating the tap grid allows for effective regional blocks, while careful closure techniques help prevent long-term nerve compression. Because of this pathway, optimal neuroaxial blockade must also extend caudally to the S4 dermatome to achieve complete intraoperative analgesia. Safe obstetric care requires viewing the abdominal wall as a dynamic matrix. By integrating knowledge of structural mechanics, vascular networks, and neural topography, surgeons can achieve higher levels of surgical efficacy and patient safety.
I hope this video was informative. Do stay tuned in and do subscribe to my channel. Much more is going to come.